How well do sensory deficits discriminate between C6 and C7 radiculopathies? With regard to how we diagnose and what and how we test and report, we tend to rely on what we are or were taught and what is required on forms from outside agencies. Yet does the knowledge base upon which these practices were created remain unchanged while the literature reflects new information that could change that approach? And although the information may not necessarily be contrary to what we do, does it suggest a reevaluation of our ability to discriminate diagnostically? For example, although there are designated neurologic deficits that are tested for in evaluating radiculopathy, how much do we know about the value or weight of these findings and their ability to discriminate between one versus another nerve root? We know that there are variations based on how dermatomes were first determined, yet there seems to be little challenge or clarification as to why. This might be explained by several known truths. We know that there is an overlap of, for example, innervation to skin, but also motor innervation to specific movement patterns, and to a lesser degree, but to some degree, deep tendon reflexes. We know that sometimes compensation can occur from adjacent segments. We also know that spinal segments are not discrete blocks of nerve tissue like vertebral segments, but in fact is a variation from individual to individual regarding how much any given segment contributes to any of those neurologic functions. A new study focuses on a well-recognized difficulty, which is how to diagnostically discriminate a C6 versus a C7 nerve root problem based on sensory deficits. Although this can, to some degree, be diagnostically resolved through special imaging, how much can be determined on the clinical evaluation? Well, first, as usual, some background and statistics regarding cervical radiculopathy. The annual prevalence of cervical radiculopathy is 4%. The peak incidence is between ages 50 and 59. Generally, the literature indicates that the percentage of deficits for patients with cervical radiculopathy is for motor deficits about 70%, deep tendon reflex deficits about 84%, and sensory deficits only 33%, so that sensory deficits are half or less than half as common. Why would that be, and is that actually true? We know that dermatome maps are based primarily on the work of either Forrester or Keegan, and that disagreement is primarily in the distal extremities. The study we will discuss focuses in on that more distal aspect of disagreement. The title is Exploration of Sensory Impairments Associated with C6 and C7 Radiculopathies, published in the Spine Journal in 2016. The patients were recruited from private practices. The inclusion criteria were that subjects were ages 18 to 90 with suspected cervical radiculopathy. Subjects presented with or without concurrent neurological complaints of weakness, paresthesias, or numbness. The exclusion criteria were neurologic diseases affecting the brain or spinal cord or peripheral nerves, distal mononeuropathies such as carpal tunnel, bilateral arm radicular symptoms, severe psychiatric disorders or cognitive dysfunction, and inability to read English. To further guarantee single nerve root pathology in participants, there was a second phase of elimination. Patients were excluded if no CT or MRI of the cervical spine was ever obtained. There was lack of CT or MRI evidence of anatomic involvement of C6 or C7 nerve root impingement, or there was evidence of multi-level anatomic findings of central cervical spinal stenosis, or there were areas of impaired sensation in the asymptomatic arm. After the second elimination criteria were met, the final numbers were 122 subjects, which were then narrowed down by 52 to result in 70 participants. 30 had a C6 radiculopathy, and 40 had a C7 radiculopathy. The researchers mapped the sensory deficits using grids as seen here. We can see that the forearm is divided into 9 grids, and the fingers and thumb and related palm are each a grid. This mapping was done for C6 and for C7. Then the number of individual deficits were tabulated for each grid. What emerges is a pattern of overlap and some discreteness for each when viewed as a color-coded rendition of these numbers. Here's C6. In this generalized rendition, red represents the most common grids of deficit, green the next most common, and yellow the least common. For C6, we see that both the anterior and posterior thumb were frequently involved, as was the distal forearm, anterior and posterior, just prior to the thumb. The anterior index and middle finger were also commonly affected. Less often, we see involvement of the posterior forearm and fingers, and the least involved was the anterior medial forearm and the palm, anterior and posterior. For C7, we see that there is also involvement of both the anterior and posterior thumb and anterior index and middle finger, the same as C6. What is different is that the posterior index finger is also frequently affected, and the distal radio-posterior forearm is less often involved. On the posterior forearm, we see that the grids on the medial side, top in the figure, and the anterior medial forearm, bottom in the figure, are least affected. So, although we usually look for specific posterior middle finger involvement, the pattern that emerges in this study is far more diffuse and overlapping with C6. Surprisingly, 83% of C6 and 78% of C7 subjects had at least one grid affected. So let's review. For C6 radiculopathy, sensory impairments were more frequent in the palmar and dorsal thumb and distal radial forearm and palmar index finger. For C7 radiculopathy, findings were also most frequently involved in the palmar and dorsal thumb and index finger and the palmar middle finger. Note again the overlap at the thumb. So what we don't know is how many grids were affected as discrete deficits in some subjects and which are deficits that include other grids as extensions of deficits in other subjects. That information was known by the researchers and so is included in summary observation statements. We do know that impaired sensation was most often found in the distal forearm and fingers. Most subjects had sensory impairments that extended to multiple grid areas. For the digits, sensory impairments were most common on the anterior surface. Sensory loss of the dorsal digits was associated with concurrent sensory loss of the palmar aspect of that same digit in 90% of the cases. And isolated sensory impairments in the palm grid areas were uncommon. For the dorsal hand, sensory impairments were a continuation of impaired sensation of the corresponding dorsal digit in 87% of cases. Sensory impairments in the proximal palmar forearm grid areas were always continuations of sensory loss in the immediately distal forearm grid area, with similar findings noted for the dorsal forearm in 86% of cases. The researchers also compared these findings with motor and deep tendon reflex findings. Motor testing was based on the following reference movements: elbow flexion for C5, forearm pronation for C6, elbow extension for C7, and finger abduction for C8. Of course, this selection also demonstrates differences in myotome standards, given C6 often is tested with elbow flexion and wrist extension, and C7 also uses wrist flexion. Additionally, forearm pronation is not a consistently used test, although some studies indicate it has value, in particular for C6. The results for motor impairments using the researchers' chosen indicator muscles were for C6 predominantly forearm pronation at 33% and for C7 elbow extension at 65%. And for reflex impairments, for C6 the brachioradialis reflex 20%, and for C7 the triceps reflex at 25%. So if we recall, the general indication from the literature was that cervical radiculopathies were associated with a motor deficit in 70% of cases, DTR deficit in 84% of cases, and for sensory deficits only 33%. In this study, there were approximately 83% of C6 and 78% of C7 subjects with at least one grid affected as a sensory deficit. And for DTRs, there were only about 30% of individuals with a deficit for C6 and 27% for C7. So what are the take-home points and application possibilities based on this study? Be cautious using older models of isolated sensory loss at the middle finger for C7 radiculopathy. Include the distal posterior radial forearm in your sensory evaluation, and with sensory loss, consider C6. For motor evaluation, add in forearm pronation, which might be more sensitive for C6 involvement. And finally, realize that the neurological evaluation is not always sensitive for radiculopathy.